Okay, let's see. Let's see if this will work. All right, you guys should be seeing a CT. This is just a quick case, but it's a cute finding that Daniela showed me. I think we've seen one of these before, but this was a trauma study, and you can see there's a kind of a small brachiocephalic vein that's compressed between the sternum and the aorta, and then there's this little second arcing vessel that courses anteriorly to the ascending aorta that comes back up and communicates with the brachiocephalic. So it's an accessory brachiocephalic vein. Probably receives some of the thymic veins. They're pretty small at this point, but there's a little guy right here, little thymic vein remnant. So I can't remember if we've seen one of these or not, but I thought it was just a cute little variant of anatomy. All right, these two are for David, because he likes the fungus cases I show.
Jeff, on that last case?
Yeah.
Was that thing coming off the aorta, did you say?
No, it's coming off the left brachiocephalic vein, and it's an accessory brachiocephalic vein.
Okay.
Yeah. And it may have opened up because there was some narrowing of the vein, the big vein between the aorta and the sternum. So it may have been a small pathway that opened, or it may have been there all along. So this is a young guy who presented with fever and cough, didn't respond to conventional therapy. And you can see he's got an area of consolidation in the middle lobe, nice middle lobe area here. No pleural effusion, and so, of course, a little bit of volume loss. One of the things we think about is around here is fungus, particularly blasto, because histo very uncommonly gives you consolidation. Coxie could look like this too, but he hadn't traveled. And I've shown plenty of cases of blasto, but just to kind of illustrate the variation of it. This is more sort of mass-like consolidation, and you do have some air bronchial veins, but you sometimes lose them. And then there's some small nodules around it. Nothing particular about this case says blasto other than the history. One of the things we think about, a few other little nodules. The lack of pleural effusion, usually with bacterial infections, we at least, especially if it's been going on for a while, we'd expect to see pleural effusion, and they often have some lymph node enlargement. And this guy does not. So this is just one example of blasto, but I wanted to contrast it with this because this is an unusual manifestation, and I got to show you the CT here. So this guy was otherwise healthy and developed fever and cough, was treated as an outpatient for, quote, pneumonia, didn't get better, and comes in, I don't have a radiograph, unfortunately, but with this CT, which looks like a complicated pleural collection, right? We've got lung forming stuck adherent to it, irregular margins, suggesting there's probably some either adhesions or septations in it. And this looks like a typical empyema. And if we go down low, he's got a little enhancing nodule in his pleural space. So, of course, you'd be concerning about a malignancy. And then this area of denser consolidation in the right lower lobe. And so maybe an empyema, but the pleural nodularia is a little disconcerting. But they actually drain this effusion, and they obtain blastomycosis from this and pleural involvement. This is the first time I've seen some significant pleural involvement. I mean, I've seen little tiny reactive effusions, but never an empyema. And whether there was another process at some point that complicated it, but he's responding to antifungals, but this can take a while to clear up. So I think this is probably the area of pulmonary infection, and somehow managed to feed his pleural space. Yeah, and again, with the bacterial infections, you tend to see more lymphadenopathy, and he really doesn't have any. So blasto is a great mimicker. It looks like cancer. It looks like TB. And it's a good time of year for us here to have it because we just recently got snow, but when it's wet out and people are out in the woods, hunting season's back in October, early November. So we've had a couple of runs of this. And then you can see it in people who don't even go outside. How that's explained, I don't know, or who aren't out in the woods. But most of the cases come from up north and along the Mississippi River, but there have been cases in our area as well as in Milwaukee as well.
Do dogs track it into the house and stuff like that? Could people get it from dogs walking in the wet leaves and things like that?
Absolutely, and a dog with blasto is actually our independent risk factor And dogs are particularly susceptible to it. If you ever Google it, there's a ton of veterinarian websites that talk about canine blasto because it can be pretty bad for them. They often will get in their eye because they're digging around in the dirt or the soil, and of course that's a quick route to the central nervous system. And I'll send it around with the case. There was a nice review article in one of the infectious disease, I think it's like Clinics in Infectious Diseases, that talks about blasto. And interestingly, my neighbor, who he does computers, but his PhD is in mycology, and he studied blasto during his graduate years. And I've mentioned before that beavers were a risk factor for it, but it turns out, I was talking to him about it, that when he looked at the DNA and all that it actually wasn't the same. And it's just the outbreaks have been near beaver dams because they're near water, but not specifically tied to the animal. So it's really a soil fungus. And it's extremely hard to find in the wild. It's very, very rare to culture it from soil samples, but it seems to pop up here every so often. And some years we'll get people coming in florid ARDS, bone or brain or skin involvement, but most commonly it's just community-acquired infection. Okay, another fungal case, and I didn't think I showed this one. If I did last week, remind me. My memory's starting to fade sometimes. But this was a patient who had long-standing.
What's in your screen at the moment, Jeff?
Yeah, I haven't. I was saying thank you.
Oh, okay.
There we go. This was a woman who's had long-standing sort of mild dysphagia that's slowly been getting worse. And this is her radiograph, and the only finding is this calcified body. And I'll show the lateral. It's hiding down here. Whoops, wrong button. There we go. Here we go. So you can see there's some calcified subcarinal lymphadenopathy. And she had an esophagram done somewhere else, and whoever did it actually did a really nice job. It's a nice air contrast. So you see the upper esophagus looks pretty good. I'm just going to go through these one at a time. You see the primary wave coming through. Let's see, go down to the next one. Now here on this image, you can see as the primary wave comes, there's this little outpouching on the lower esophagus. And I'll show some more images. And there you go, it persists, yet the contrast is clearing through here. So looks like there's a little diverticulum. And these may be out of order depending on how Cyrus did it, but you can see as it's expanding here, you got this little diverticulum. And notice this density here. That's that calcified lymph node that I showed you, our mat of lymph nodes. There's the top of it. There's that calcium in the mediastinum. Comes down to the lower esophageal sphincter, which eventually opens up. You can see it opens up here into the stomach. So that's really the only area. And then I think there were some prettier images. Let's see, go a little bit lower. There you go. So there you can see that diverticulum with air in it now too. And there's those calcified nodes. So this is a beautiful example of a traction diverticulum, which are traditionally described in the setting of tuberculosis. And I'd only seen it once as a resident in the teaching file at the University of Washington of a TB case. And I came across this case because the surgeon, she was referred to thoracic surgery, and they ordered a CT. All it shows is there's the esophagus, there's this big calcified blob. The esophagus, yeah.
Anything on the spleen?
Yes, that's why it's histo.
Right.
So yeah, we called this a traction diverticulum from histoplasmosis, and there's really nothing you do about it. Her dysphagia is not that severe, but I guess the surgeon was not inclined to go in there and do anything because it's not like you can just resect the diverticulum. It's all matted down. So it's almost like a localized fibrosing mediastinitis, but it's just because of this bulky node. So I've never, we see tons of histo. Pretty much every other patient has some findings of it, but it's the only time I've ever seen a diverticulum from it. So that was kind of fun. So those are the three fungal cases. Now here's a non-thoracic case, but this is something I have never seen before. And talking to my colleagues, they hadn't seen it either, and I'm going to hold on. So this one I came across only because I was looking at what was going on with the diaphragm. And this is an old case. This is 2014, and this patient had previous trauma. You can see there's these hyper-enhancing or dense nodules in the upper abdomen. As I scroll down, you'll see there are a whole bunch of them all scattered out through the peritoneal cavity. I'll just stop at a few levels. But you get the point. They're everywhere. And the spleen's absent. So this is an example. I think some of them went all the way down towards the pelvis. Yeah, there's a big guy here and some little friends nearby. This is a guy with peritoneal splenosis, which I have never seen. I mean, it makes sense. I'm surprised they don't see it more often. My theory is when they go in and do an X-lap, they frequently kind of flush everything out at the end with saline or whatever and suck it all out. But considering how many traumatic spleen injuries we see, I've never seen it. I've seen more cases of pleural splenosis.
Wow, that is interesting.
Yeah, so I thought it was just a fun case. Nothing to do with the chest, but something I don't see. So I had that one. And then I'm curious. This is a straightforward case, but this is a fun one that you could show for a residence or an unknown case conference. So, patient has a long-standing illness, and if you've already picked it up, you probably already know the diagnosis. But you've got all these lung nodules and all these skin nodules. And this patient presented with a thigh mass. You see the swelling, and then here's a better view down low. Big thigh mass. And if I go back to the radiograph, you can see more skin lesions here. And I threw the MR in for fun just to show you how, oops, hold on, hold it away. Just how ugly the thing is. It is a big guy. And I think on the axial post-contrast. You notice all these skin lesions. See them out in the periphery of it. This thing, really ugly. So if you haven't figured out already, which I presume most of you have, this is metastatic malignant peripheral nerve sheath tumor in a patient with neurofibromatosis. But this is one of the ones where the diagnosis is on the images. Now, I suppose these could be mistaken for neurofibromas, but not all of them have the appearance typical of a skin lesion. And then here's the CT just showing all of these. Typical sarcoma mets, very rounded, well circumscribed.
Yeah.
So now this is cool, and I have not seen this with this particular cancer. So and I'm going to show the screen. So this is a guy who presented with SVC syndrome back in May, and had a mediastinal mass, had a stent put in to relieve his symptoms. And here's the CT that was done 2 weeks before that radiograph. I don't have a pre-radiograph, but it gets the point across. So here's this big, ugly, infiltrating mass in the prevascular mediastinum. Thymic neoplasm, maybe a small cell, something else bad. This ended up being thymic carcinoma, which doesn't surprise us given how aggressive it looks. He had been given chemotherapy, radiotherapy, and this is the scan from December, which shows that the mass is much smaller, and you can see the radiation-induced injury, classic postage stamp PAAP radiation. But that's not why I'm showing this case. But what was different on this scan is he had developed, and these were all new compared to his scan from a few months before, these little Cheerio lesions, which I presume are metastases.
Gosh.
But I've never seen a thymic carcinoma. Unfortunately, I didn't dig out the exact pathology subtype of it. So it's possible there was a thymic adenocarcinoma, which would explain the Cheerio appearance. But as far as I know, it wasn't a weird mucinous variant or something. But I've never seen thymic carcinoma mets look. We see this more with colon and lung. But add this to your list of Cheerios.
This developed in what period of time?
3 months.
I see.
Yeah.
Wow.
Never mind. The tumor itself is obviously responding to radiation. Presumably the chemo wasn't helping because these appeared. And I went back trying to find even an inkling of any of them, and they weren't there. So these showed up very quickly. I have not seen that appearance of them. All right, that's all I got. So Travis will just be an observer, as I said, but if David or Howard, you have a case too.
Okay, I do.
All right.
Let me start off with a nice anatomy one that you showed, a nice anatomy one. So here we go. Let me start this in this fashion. So go from below down, and we'll look at the azygos, hemiazygos veins and go up. So keep your eye on the azygos vein as we go up, and about here, it's not crossing over, and it's getting some blood flow from some intercostal veins there. Usually there's a separate right superior intercostal vein, but it keeps going, and then you can see here, boop, it goes across. So it's going across there, and it's going to drain into the, as best I can tell, the right brachiocephalic vein up there. And what's interesting now is, let me just bring up the thins to show the same thing a little bit better. So let's first just scroll up there, go all the way up where it crosses over, as you can see there. Now, here's an accessory fissure, but notice it's all by itself, and it sort of ends here near the brachiocephalic vein. There's a little bit of fat there. So let's see if I can bring that out a little bit at the end of that fissure right there. Sorry, right there. So I don't know if you've seen that before.
Howard, was there an
This
azygos?
is fat right there. Pardon?
Was there an azygos vein arch farther down at the usual level?
No, nothing over here, right?
So could this be an escaped azygos vein? It's been described in patients with azygos fissures where the vein pops out at the fissure because it's not truly in the lung. I've seen a couple cases following surgery where they drop the lung, and there's a few descriptions of it in the literature. I think we've shown a couple, or I know I've shown one.
Yeah, you've shown a couple. I've seen them now that you've mentioned them too.
Now, if the azygos vein popped out, then it should be more medial along the mediastinum. Yet, and it is mostly, but yet it still crosses over here to join that brachiocephalic.
So Howard, go up to the top. Is there pleura above the vein, or is it all? Because I saw a little membrane. I don't know if this is just part of the vessel. There is a little, looks like a little thing there.
There's another fissure.
So it's an accessory azygos fissure.
Yeah.
So there's a little fissure type structure right up top here.
Yeah.
And then there's the azygos, and there's the other fissure.
Very interesting.
Yeah, I'm not sure how to classify this exactly, whether it popped out or it's just one of these.
This is an
You can find
anomaly.
reports, yeah, it's funny. You can find reports of an accessory fissure here, described just as an accessory fissure, and where you have even the right brachiocephalic vein can be intrapulmonary or seemingly intrapulmonary. So variations on that theme have been described, and I'm not quite sure what to make of this. In other words, it's just a variation on a theme. I don't have a history of trauma or anything like that. And then there's this additional thing way up there. Okay.
It's a variant.
Yeah, so I don't know how to describe it. I'm just going to describe it as a variant, yeah. A separate fissure, and then the azygos. The azygos seems to be just continuous, and it gets some blood supply, so there's no separate right superior intercostal vein separate from this guy. I think all the blood flow that usually goes into it goes into this vein. So just a variation of anatomy, which is interesting, right?
Yeah.
Okay.
Wow.
Just curious, isn't it? All right, this one over here is an interesting case. So I'm going to kind of present it as it kind of happened. So here is what a radiograph would have looked like back when this person had something discovered back in November. And you can see that there is an abnormality here in the superior azygoesophageal recess subcarinal region, which is this thing. So I'll scroll through that and give you a feel for what this looks like. Now, we may want to come back to that in a little bit, but let me just tell you what happened afterwards. So at some point, a A procedure was done, so we have endoscopy getting involved. They went down there with an endoscope in the esophagus, described that as not a cystic lesion. So the assertion about it not being a fluid-filled cystic lesion was pretty definite in the medical record. And a transesophageal biopsy through the endoscope was performed of this thing, and then the patient was let go and submitted to pathology and so on. And then he went back to his hometown, and that's on the 17th. So now we go forward some days here to the 27th, where he's imaged at the outside institution, and you can see not good. That whole thing is bigger than it was, and you can see a little bit of air here, and you can see a little bit of fluid in the pleural space. So here we are on chest radiography on 12/1. Nasty. So there you see the fluid level now going all the way across that thing, as you can see there. So now it's got a long fluid level in it. Here's the CT on the same day, on 12/1. And it looks just as you might expect. Now there's a fluid level and there's lots of air in it. It goes all the way across. Effusion is bigger, not good at all. And then that was drained. So here you can see placement of a catheter into it. And now I will show you the op report that you can see there. And you can see that it was removed. And you can see the op report. It's consistent with a infected cystic lesion, a bronchogenic cyst or a duplication cyst. They found the communication. There was an esophageal perforation. And here you can see what was cultured from that. So, you know, he's not doing well. Eventually he had the surgery, and the most recent thing is he has a stent there to try and close the hole between the esophagus that still persists in the lesion. So this is not a solid lesion. So if we go back there and we sort of do the usual thing here and measure things, you know, the numbers are relatively high, as in 48 and so on. But this isn't a solid lesion. It was described as solid, but isn't. So presumably pretty proteinaceous. But you can see what happened. So that's kind of scary. So one really has to watch out. Any thoughts other than oops? Guys can still hear me?
Oh yeah, we can hear you. We're still
Just checking.
processing through this one. Can you scroll to the mass again, Howard? Just the initial.
Okay, so this is the initial one.
Yeah.
There we go. Yep.
It looks like pretty well circumscribed there. Yeah. Yeah, it goes up pretty high. Yeah, we're talking about going towards the left pulmonic recess. Do you guys routinely get MRs for these if you think it's like a proteinaceous cyst in this location?
I'm certainly thinking about doing that more often when you get those higher numbers and it still looks like a cystic lesion, well circumscribed, relatively low in attenuation, maybe a little bit lower in attenuation compared to muscle, but you do wonder, don't you?
Yeah.
And I know that we have another case here in which Lev did some, and I'll try to get him to show the cases, but he did MR and he also did some additional vibe sequences after Gatto and showed some features consistent with a cystic lesion rather than a lymph node. A different case from this, but in terms of problem solving, MRI can be really great at solving the issue. Is this really a cystic thing or not?
Yeah, we've done on a couple where it was, like you said, it was higher attenuation, but in the right location, fairly homogeneous, well circumscribed, clearly has a high potential to be a cystic mass. And that way, because I mean, I think the problem with ultrasound is if it's complicated or complex, you know, there can be adaptations that they may have a harder time with it. And that way,
So,
the surgeon, if it's cystic, the surgeon just goes in and takes it out as a bronchogenic cyst.
Howard, what sort of CT numbers did you get out of it? Did you say?
Yeah, let me do it again here, Dave. You know, the 40s, 50s, around there, you're in the 50 range,
Wow.
45.
I wonder if it had bled and there was some, you know, some blood products in there or something giving it that higher density.
Yeah, I don't know. Maybe very pronounced.
Or just mucus. Maybe it's, I've even seen them calcify sometimes. The mucus can calcify. So it's probably pretty proteinaceous, I guess, with a IC tumor like that.
Yeah. Obviously, when we initially got to see the case here and thought about it, this was a big wow when we saw that fluid level and ostensibly a solid mass, right? That was scary. Yep. So that's a gotcha. That's a watch out. All right. Let me show you this interesting case. The background here, and I'll tell you more in a moment, is a patient that had lymphoma years ago. Eventually did have initially an autologous transplantation, but there was a recurrence. And then she did receive a form of allogeneic stem cell transplantation. That happened in 2011. Since then, she's been doing okay. She does have some manifestations of GVHD in the form of skin GVHD, but otherwise has been doing okay. She came here, and this is from April, looking like this. And you can see we have the situation we see quite commonly where we have diffuse, patchy, multilobar, confluent ground glass, and maybe consolidative opacities. And we've got the usual differential diagnosis for that, which includes infection and non-infectious disorders. And then we try to limit the diagnosis depending on how much time has elapsed from, in this case, the allogeneic transplantation. And there's a differential diagnosis for that. But what was really interesting was she was treated with steroids. So this is the 28th, and it dramatically got better. So that's from 4/6 to 4/28 of 16. And the only thing that she received was steroids. I can't remember if she did have a BAL to address the issue of infection. I think she probably did, but she didn't. She just had a dramatic response, as you can see there, to steroids. So that's back in April. And then she came in with a similar episode, but not so severe, in September, but I don't think anything was really diagnosed there. So that's September. And I don't think any particular diagnosis was made, but she wasn't that sick there. So here is the CT from September. And it actually looks really good. So nothing was really going on there. She came back more recently now, so this is December, and now you can see pretty much the same thing now that she had in April. It's the same phenomenon. Again, no signs of infectious bronchitis or bronchiolitis, no pleural fluid. It looks very much the same. So I suggested that she just has maybe a recurrence of the same phenomenon, which may be a form of, call it steroid responsive, GVHD. And in terms of what might be in the lung, and that's just a presumed diagnosis, she actually was discharged the other day, so she's doing okay. But in terms of what you might find if you biopsy patients and if they have this, are things like what's described in this article here as, they described it or classified it in 3 ways here, as a form of acute lung injury, which of course could be a limited acute lung injury with some intraalveolar fibrin, reactive pneumocytes, a OP pattern with or without fibrin, and what they just called a interstitial cellular interstitial pneumonia. So of course I speculate that she may have had a mild form of one or more of these pathologies that we see there, but has responded or will respond or seems to be responding to steroids. So they up the steroids and let her go home. So I'm not sure if I've seen this before, but I think it's maybe a very nice example of that. I don't know what other explanation one can come up with for this kind of pattern other than a mild form of GVHD. Any thoughts, David, or anyone else? What else to call this?
Yeah, I mean, we see this not infrequently in our transplants and give the same song and dance of GVHD, infection, maybe a drug reaction. And it's often organizing pneumonia pattern for acute GVHD. One thing I have noticed is they almost always have skin and or gut involvement. I've not seen it as the only site. That can be helpful in trying to limit the differential.
Yeah, she has, I think, chronic sort of low-grade skin GVHD. So someone emailed me about this one for the more recent thing, and this was kind of my response. And she does have some what's called stable sclerodermatous chronic GVHD. Interesting, huh?
Right. So the main differential diagnosis is viral infection and pneumocystis for that upper lung predominant peribronchial ground glass abnormality.
Yep.
So what they do around here is they make sure that the person's not infected.
Yep.
By bronch and lavage and testing the nose for viruses. At that point, they put them on steroids and the stuff melts away. And we have a current case that looks a lot like this, where it has, just as in Howard's case, it's come back now several months after the last episode. It ends up looking the same for another round. We have a current case just like this. And there was some investigation about a couple of years ago. And it turns out that if you look at these cases for second-order viruses, things like human metapneumovirus and HHV6 and things like that, about almost 50% of the time you can find that there's actually a virus that you didn't look for on your conventional viral testing. So a lot of these cases are probably smoldering viral infections that lead to this organizing pneumonia pattern like this. If you look hard enough, you can reclassify some of them as viral infections. Either way, they're steroid responsive.
Yeah.
So
I think there's some evidence to indicate that sometimes a viral infection ostensibly can produce an organizing pneumonia pattern on pathology if you have pathology to look at.
Right.
Yeah, exactly. This is 3 days between these two scans more recently, and to my eye, I think it's a bit better. It's only 3 days, but it certainly looks no worse. So this time, because she didn't have signs of infection, they decided not to do a BAL. They just treated her with steroids and are just letting her go home. She's doing much better. Interesting. All right. Let's see. Well, this is a pretty dramatic case, so let me show you this one. This was a person that was imaged in the context of a diagnosis of CLL. So everything you're going to see here was a big surprise. So a huge mass. You can see its location, its size, how it enhances with contrast medium, lots of areas of necrosis within, how it's growing between structures and pushing structures away. And ostensibly, he wasn't even symptomatic from this. This was a big surprise. So, of course, this was biopsied, and this turned out to be a paraganglioma. You can see up here it's got some really big vessels supplying its superior portion. So, very vascular thing. So we had that resected. They had to sacrifice the left recurrent laryngeal nerve. In order to get that out, according to the notes, they had to do a patchplasty of a pulmonary artery in one place. But otherwise, they got it out. And his CLL is doing just fine. And he comes into the clinic and he gets imaged in clinic visits at intervals. And he's doing okay. But unfortunately, with the most recent visit that I read, I can see recurrence of it. So the time interval here is 3 years. Full 3 years have gone by. And oops, right here, unfortunately, it has come back. It's not very big, but given what it looked like before and what I see here, I was pretty confident in diagnosing recurrent paraganglioma right there, just between the subclavian and the carotid. So they're kind of wondering what to do with him because he's doing okay, but they're spending time thinking about what to do with what is very likely a recurrent paraganglioma. So
Howard,
pretty interesting.
did the first one go up that high?
Let's have a look up here. So we go up,
Yes.
not quite that high up there.
It's right between the left subclavian and left common carotid. There's a little bit of it up there.
Yeah, I wonder about that. That's pretty close.
I was just wondering, could it be a second one? But
Or a second one. Yeah, it's possible. I mean, it's close. Maybe there was a lip tissue there, I guess. But you're right, there wasn't a bulky mass there, but there was maybe a little bit.
Another thing,
Pretty close, not quite there.
Another thing, when you were showing the original one, it looked like, can you scroll down slow? Right, see that vessel running along the posterior margin of the mediastinum on the right above right there. Follow that out. It looks like it's coming into the pulmonary vein, and I almost got the sense that was draining into the tumor.
Oh, that I think is just an anatomic variation of a pulmonary vein on its way to the...
But coursing in the mediastinum. See, there's two vessels there.
Oh.
If you go up slowly, there is one that goes posterior, one goes into the lung. But the one end, see that vessel coursing along the posterior there? Follow that into the tumor. It looks like it drains into the pulmonary vein.
Or it goes in front of it, or
I couldn't tell right away when you were scrolling if that was, or just went somewhere else, but it looks like it drops into the left atrium.
I think it's going anterior to it.
Right, but if you go lower, it looks like they join together.
Somewhere there.
Yeah, keep going down now. See, right there, it just looks like it dives into that larger pulmonary vein. Right there, it looks like they come together. And
I don't know.
Left atrium. Like it's opened a pathway of the...
Oh, don't know. What's going on there, Richie? It is curious. I didn't notice that.
If you go up higher, it looks like it goes into the tumor. I don't know, it was just weird.
Yeah. Oh, I don't know.
You see mediastinal varices do that. So, when you've got vascular things going around, they'll sometimes find pulmonary veins to drain into.
Let's see if I have any more images from 2013. There are MRs there, so I didn't show you that. But I can look later to see if I see any veins. I don't know if that will help or not. With respect to this thing down there. Not sure. This is a bit later, after contrast administration. So you're wondering about a connection right there and then going in.
Yeah, right in that spot. It looks like that's vein. I think that's what's happening.
Don't know. Curious, huh? Okay. Does anyone else want to show cases? I have a couple more that I could show you as well. Up to you guys.
A couple of cute ones.
All right.
Okay. Good.
Okay, so this was a B reading that was sent to me this week. And I decided this was abnormal and called the group that coordinates this B reading program around the country, and was told that the woman has stated on her physical exam that she has an abnormal chest X-ray. So she and I were in agreement. She does indeed have an abnormal chest X-ray, but this very symmetrical upper lung scarring and cavitation, and then something in both cavities, Tom Mohammed has sent me cases like this from Cleveland before, but this is the first time I've ever seen one here. And I think this lady was from Eastern Washington. So my interpretation of this is with this symmetrical scarring and cavitation, if you just had this on one side, you think about TB, but when it's symmetrical like this, it's usually sarcoid. You can see the traction on the highlight here, and so I think it's sarcoid with scarring, cavitation, and then bilateral symmetrical mycotomas.
Yeah.
Those cavities.
Great. Yeah.
Jeff, did you see stuff like this in Cleveland? Because Ton had sent me cases from Cleveland that look
Probably
like
the
this.
same cases.
What?
Probably the same cases because we overlapped for 3 years.
Yeah.
Yeah, I mean, we see sarcoid here, but I have one case with bilateral aspergillomas, but these are quite large. But I agree with you. This doesn't look like pneumoconiosis.
Right.
Great. Yeah. Lovely. So-called monad. Excuse me. Monad.
Monad. I think it's
Monad.
monad.
I think he's
OD.
a French person, right? Monad or something.
Yeah. So we should not call this the air crest sign because that confuses it with invasive aspergillus. So is it MONOD or MONAD?
I forget. I'd have to look it up. I know I have it somewhere. And
MONOD.
I'm not sure why he was rewarded with describing the sign. The article that I eventually did find was in French, so I couldn't read it, but he was an author of something describing something like this, yep.
Okay.
David, my resident and fellow are laughing. The grin on my face from seeing this radiograph is a mile wide.
Why is it so amusing to you?
It's an amazing radiograph.
Okay.
It made me happy. I mean, that's a fantastic radiograph.
Okay, well, happiness, that's our goal around here. Okay.
Yeah,
so Merry Christmas. So here's a Chinese woman, an elderly Chinese woman in her 70s at the time of this radiograph, who has a history of childhood tuberculosis when she was 5 years old, and her father died of fulminant tuberculosis, so she was exposed at that point. And what struck me about this case was the number of calcified lymph nodes in the neck. And I'm trying to get an older chest radiograph scan that goes even higher up and shows that these calcifications went way up. So this is indeed tuberculosis, and she's got, let me see if I can find a good series here. She's got mediastinal lymph node calcifications and lung calcified granulomas as well. She also has some peripheral fibrosis. She's a cigarette smoker. She died of pulmonary fibrosis and old age. And unfortunately, the CT scan of the chest doesn't go high enough in the neck, but we may be getting into one of those calcified nodes. So this would be calcified tuberculosis in the neck in the scrofula kind of distribution. There wasn't enough history to tell whether she'd ever had scrofula in terms of draining sinus tracts coming from her neck as part of her childhood TB. She was not a good historian, and she didn't speak English, so we don't have detailed history. But a lot of neck calcification, and she also had one, I forgot to show you, she has one splenic calcification. So Sadaka or Pipavat says that in India, the most common cause of splenic calcification is TB. In this country, it's histo, and we often use that as a distinguishing feature to say it's likely histo. There's one little calcification, and not TB, but this shows you that you can get, of course, calcifications in the spleen from TB.
But David, but have you ever seen? I've never seen. I mean, it makes sense because it's the same drainage of the pathophysiology. But with the histo, though, I showed the case earlier today had tons of calcifications, and I've never ever seen that with TB. I've seen a couple. Chris was saying fewer than 5, which kind of makes sense, and that's what they did in Cincinnati, where they had even more histo than we have here. But I think that's a pretty good rule of thumb. If you got what I call the speckled spleen, you can chalk it up to histo.
Okay. So then I'd like to show you a case of congenital heart disease or congenial heart disease, depending on how well disposed you are to it. So this person has a fairly normal looking radiograph, except on lateral view there's fullness back here, and on CT it turns out that there is a cystic abnormality, which is kind of asymmetric and seems to be hanging out like this. And let's get some ROIs on it. So we've got 23, so that's nice and low. And I think that this is probably a cyst, a bronchogenic cyst. And then there's this lung lesion down here, this kind of balled up lung lesion that looks as if it's got some bizarre bronchi in it. I think these are bronchi and not just holes, but they're rather bizarre, and it's very, very contained like this. And this scan was done here in 2011. We have older scans that go back more than 10 years from the late 90s before they were on PACs, and it looked just the same. So I believe that this is probably another congenital lesion here associated with this bronchogenic cyst more medially to it. And I don't know what to call this. I don't have a good name for this. And everything has stayed very clean around this thing. It doesn't look, the person does not have symptoms of chronic infection. This is really almost an incidental finding on these scans that were done for some other reason.
And there's no almost
long stability to it. I didn't see any blood vessels that were entering this thing, systemic blood vessels getting into it.
Could it?
And it's not.
Could it be? Looks almost like a bronchogenic cyst coming off the inferior pulmonary ligament. That maybe it's confluent and it's just all maybe got infected at one point. Because if you trace it inferiorly, it goes right along the inferior pulmonary ligament towards the esophagus, right there.
It all seems to be one continuous thing, doesn't it?
Yeah.
That's
But I've never seen the air collections with it, so you wouldn't invoke a separate bronchial dysplasia of some kind associated with a bronchogenic cyst.
It doesn't look like a CPAM, and there's no anomalous, systemic arterial supply. But if you follow it all the way down, it goes right to the inferior pulmonary ligament. That's why I was wondering if it's just part of the same cyst or it's a second bronchogenic cyst.
But it's got air in it, so it's getting air from lung. It's intrapulmonary, or at least in part, even though it's all contiguous. Oh.
Okay, so some bizarre lung thing, and so maybe it's acquired aeration or something like that.
That's what I would think.
It's got little vessels that are coursing through it that are branches of, I guess, pulmonary.
Off the pulmonary circulation.
We don't see big bronchial arteries or anything else nearby.
And I don't see systemic arteries getting into it, but I think some of the pulmonary arteries are getting into it.
We call it a pseudo-CPAM.
You're going to call it?
A pseudo-CPAM.
Hybrid coincidental CPAM-like thing and cyst. That's curious.
David, I suspect this was a giant bronchogenic cyst that involved lung and and mediastinum and got infected at some point.
Okay. Okay. Well, those were three cases. These are old cases that I'm rummaging through and scanning older pre-PACS radiographs when necessary. So these three cases have popped up in this context. Well, actually, the first case came up from B reading biz, but.
Howard, if you don't mind, I've got a companion case to your azygos. Maybe one I showed before, but this was a guy who had you can see my screen, had a traumatic pneumothorax. You can see the pleural drain is in there from blunt trauma, and you'll see there's his azygos here, and there's the fissure. And
okay, so
it arches up like that, and there's the fissure. So this is an escaped azygos vein. But the difference with my case is I don't have that accessory little mesoazygos that you had, because the
tiny one
is just hanging out there on its own. So I think yours is truly an accessory fissure with a aborted azygos fissure. And then here's another one. This may be a case.
So Jeff, was that a trauma case or was that a surgery case?
That was
this last
trauma case.
I'll bring up the previous again, and let's see when that azygos goes adjacent. There's pneumothorax, isn't there? And where's it going actually?
So
I was intrigued.
Yeah, so it pops up actually. Here's the pneumothorax. It's sitting.
Where is it sitting?
Right on top of the pleura, but it seems to. It's hard to know if it's extrapleural or what, but it looks like it's sitting in the pleural space. It's surrounded by air here.
Very curious.
Unusual. Let me make a coronal of this one, see if it looks. So there's the azygous vein coming up, arching over, and you can see it looks like it's actually contained by some pleura, because otherwise it would kind of hang out there. It looks like there's visceral pleura. But, the traditional teaching is this fissure is of 4 layers of pleura, and so the azygous is technically extrapleural.
Right. Well, it still is, Jeff. So those are 2 layers of pleura, but they are parietal pleura.
Okay.
And it's escaped from the visceral pleural fissure.
Okay.
So it's on a mesentery of 2 layers of parietal pleura.
Got it.
The course of this one is almost identical to mine, and
there you
the
go.
same.
Right here, David. You can see sort of the little mesoazygous, as it's referred to in the literature.
Right. Yeah. Cool.
And then I found another one, and this one has your name on it, Howard. So I don't think this is the same case. Let's pull this one.
Only I've seen it before.
This is the same case.
Oh, yeah, I've shown it before. Wait a minute. No, wait a minute.
Or maybe we were talking about it, and you just sent it. You sent it to me or something. But I think it's the same one, because there's the fissure, and here's the azygous coming up high, and there's that little mesoazygous.
If I can show,
but it is possible.
if I can show one really quick too.
But it is possible that this actually popped out of this fissure at some point, and it took the mesoazygous with it.
Yeah, that's not a bad idea. And the lung is just folded around it.
Right. So I think the difference is mine has the pneumothorax, but I bet it's the same mechanism, because it would make more sense to. Why would you have this? The reason the azygous fissure even forms is the vein transits, pushes it, invaginates into the lung during development to lead to it. Okay, Travis said he had one. Let's see what he has to share.
Yeah, I can show one really quick. You see my screen?
Your ass.
This is the before and after. This is you can see the nice azygous vein even with the valves in the middle of the fissure here. And then this patient underwent I think it was a bilobectomy. But let's see, I'll just pull up one of their post-op studies. And you can see now there's the fissure, and there's the azygous vein back along the mediastinum. And you can see they got more metastatic disease by this point. But yeah, so it popped out when they did the right middle and lower lobectomy, or I guess just to
keep scrolling, Travis, because yours hugs the mediastinum quite nicely immediately.
Oh yeah, it does. It kind of popped completely back into the mediastinum where it should be.
So there was a paper, I think in AJR a few years ago, not a few years ago, probably within the last 10 years, that talks about this. And if I recall, it said, or at least another paper said, it can either go back to its normal position or it can hang out at the lung, like at the top of the lung.
Okay.
There's a difference in the thickness because you lost 2 layers of parietal.
Oh yeah, and Chris made a great observation. Look at the change in the thickness of the fissure after you lose 2 layers of parietal pleura.
Huh. Yeah, that's a good point.
That's cool. But in that,
if you showed the first, I had never seen that until you showed a case of this a couple years ago.
I know, it's funny. I remember seeing one and wondering how many times I'd missed it going back, because I've subsequently seen a few cases of it, and there are case reports of it. But I think the Yellow Journal paper described it nicely and showed that that it either went to where yours went, Travis, or where Howard's went, where it kind of just hangs out adjacent to the lung apex. It doesn't move all the way. And I think I have a few more cases of it. We had one post-trauma, I had one post-esophagectomy, and I think another post-lobectomy or spontaneous pneumothorax. So
that's great. So looking at the thinness or thickness of the fissure may help as well. If it's really thin, then you wonder that it's lost the 2 layers because it popped out. Oh.
Yeah. I'll go back and look at mine again. Yeah, the one I showed you guys, let me pull it up here, has a very thin fissure. Let's see. Yeah, you see how thin that fissure is. Looks like a typical fissure of 2 layers of pleura. Unfortunately, I don't have a pre-trauma on this guy, but yeah, this one was traumatic. You don't really see the mesoazygous except on the coronal, that little tethering of it. So, all right, well, it's 3 o'clock here, so time to wrap up. But that was fun.
Yeah.
I'm around
Excellent.
next week. I don't know. Are you guys around next week?
Yeah.
All right. Well, let's plan on meeting, and if we have cases and people, great. If not, we'll just postpone it a week.
Thanks, everyone.
All right.
Merry Christmas.
Okay, that's good.
Happy holidays. See you guys.
Thanks. You too.